Sorry. Can I start?
Yep.
Yeah. This presentation about treatment. Yes, it's a presentation. Can you see the presentation?
Yeah, we can see your presentation quite well, yeah.
Perfect. The presentation will talk about our report of ligament lesion for R. Yeah. The first stabilizer, the scaphoid of the scaphoid joint scaphoid that is divided into the dorsal polar and the inferior part. The secondary stabilizers are the palmar ligament. This is very complex condition of the ligament wrist. The most important ligament that stabilize the scapholunate complex are the capillary, longer adrenal ligament, short and the polar side. The dorsal side. There are the trichum and the dorsal ligament. When we talk about the repairing of the ligament, we can divide the lesion of the ligament acute or chronic, but it is wrong, not correct. What we need to understand which part of the ligament tears, and in this figure you can very perfectly state and level B are the lesion in which you can perform the repairing into the bone. In the other part, you cannot do nothing because the ligament is damaged in the internal side. And so they have poor healing potential. The other parameters for understanding the algorithm of treatment are that Garcia Elias in 2006 proposed. Is the dorsal ligament intact or partial rupture? If repaired, has good chances of healing? Is the radioscaphoid angle normal? Is the lunate covering this normal? Is the misalignment easily reducible, or are the joint cartilage normal? All of them have to be considered before to do a treatment of the scapholunate ligament. Because if you don't do that, you can happen a failure of the treatment. Arthroscopy is the gold standard. There is no other one of possibility to perform a correct diagnosis of the damage of the ligament. In my previous experience, I did a comparison before arthroscopy and MRI 1.5 Tesla, and we found that in a complete tears of the scapholunate, you can have an 85% of the confirmation by arthroscopy. But if you have a partial lesion of the scapholunate, it drops out until 20% of the condition. So 80% of the conditions are completely missing. This is, for example, a technique of evaluation from the mid-carpal joint. Arthroscopy, what needed? Looking for the condition of the scapholunate ligament, all parts, dorsal volar and inferior part, proximal part, location of the extension of the lesion, and the damage of the ligament, and the condition of the ligament, of the cartilage, because if it's a chronic lesion, you can have already the cartilage damage and osteocartilage damage. From the evaluation, arthroscopic evaluation point of view, you can perform by probe the technique of Hock test proposed by Corella, or the pushing of the scaphoid in the dorsal side to evaluate the translation of the scaphoid in the dorsal side proposed by Corella, and the rocking motility of the lunate when is involved the scapholunate ligament and the lunotricular ligament that frequently could be associated. This is a particular modification of the Gessler classification that Messina with me and Matulin did at the time, more than 10 years ago. Because we have seen that there was some difficulty to include the lesion of the ligament in the classification of the Gessler. So the most important part is the three. The three level, you can have the dorsal, the volar lesion, or volar and dorsal. And so we classify that in 3A, 3B, and 3C. 3C, both volar and dorsal, B, only dorsal, A, only volar. And so you can address your technique of repairing or treatment in the lesion, in the perfect lesion that you have found. The 3R, what is the 3R? More than 10 years ago, I suggested to use a correct terminology. And Korea changed it from 3 to 4R. What are them? Are the technique of repair, reinforcement, reconstruction, and resection. And because we use that, because frequently when in the publication or in the meeting, the speaker talk about of a reconstruction where they intended acute lesions, so they are repairing, not reconstruction, or use reconstruction for reinforcement, capsulodesis. This is another thing. So just they produce a misinterpretation of outcome data. So, for example, dorsal capsulodesis used for the stage 4 and stage 3 absolutely fail, because the stage 4 you have to use the reconstruction, the stage 3 the capsulodesis, that is not a reconstruction but is a reinforcement. And it's frequently used reconstruction also for repair. Once more, correct scientific terminology allows us a correct interpretation of the surgical technique to use, obtaining correct outcome results and possible more correction outcome comparison. So 4R, repair, reinforcement, reconstruction, and resection. Resection is to include also the arthrodesis or arthroplasty. Open surgery and arthroscopy could be available for this kind of treatment. Repair, consider the repairing of the suture, direct suture of the ligament. Reinforcement is the capsulodesis or augmentation, volar dorsal or volar and dorsal. Reconstruction are tenodesis, using the extensor carpi radialis, or reconstruction with the box 3LT proposed by Garcia Elias, by Herrick, 360 degree, etc., 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 and bone ligament bond. Resection, arthroplasty, and arthrodesis. All of them are included in the classification of Garcia Elias. The classification of Garcia Elias is fundamental. For the stage 1 and stage 2 of algorithm proposed by Garcia Elias, we can use the repairing and also part of capsulodesis. The capsulodesis reinforcement is typical for grade 3. In grade 4 and 5, is mandatory to use the reconstruction because the ligament is completely absent. And so you cannot do any reinforcement of ligament. If you use a reinforcement, you use a reinforcement when the ligament is present, but this is insufficient. And last is the resection and arthroplasty for grade 6 and 7. Repair. Which kind of repair? Repair you can do only when the ligament is in the particular part close to the bone. When the ligament is damaged in its territory, in this continuity, you cannot do any kind of repairing. You can make a suture, but the suture fail, and so you need to make a pinning and also a reinforcement of the ligament. So the first part of algorithm that we proposed is in acute lesion ligament and subacute injury. We can perform the repairing, but we can associate also the reinforcement when the ligament is torn in the middle and not close to the bone. In the other part, can perform the reinforcement. And the reinforcement is, I repeat, capsule daisy, dorsal volar, or dorsal and volar. We have a lot of possibility, starting from the Berger, Szabo, and other guys like Vigas for the dorsal part, but we have also for the volar part the technique of Van Kemplek from Miami, from the Mayo Clinic. This is the technique of the dorsal reinforcement proposed by Berger, but was modified by me, that I preserve and maintain all the dorsal ligament, the dorsal extrinsic ligament. I published this paper in 2011. This is dorsal capsule daisy, preserving the dorsal ligament and making a reinforcement of the dorsal part of the scapholunate ligament. Another possibility is totally arthroscopic, proposed by Matulin. Perfect, because you cannot open anything, but you need to have part of the ligament. You can fix the dorsal capsule, the dorsal ligament, extrinsic ligament with the dorsal remnant part of the ligament. These are for the dorsal part of the ligament. You can perform also the dorsal round block as proposed by Andrea Zey. This is a fantastic technique. It was published recently by another college from Belgium. And for the volar side, we can use the technique of Del Pinal, that uses the reinforcement of the volar part of the capsule to the volar part of the ligament, the scapholunate ligament, like proposed in this kind. The same technique proposed by Andrea Zey for the dorsal part could be used also for the dorsal side. Sorry, for the volar side, reinforcement, reinforcing the scapholunate, volar scapholunate ligament. And this technique is fantastic to make a stronger resistance and capsule daisy of the volar side. What we can do for the reconstruction, a lot of possibility. This is valid for the chronic lesion. There is no ligament absolutely, so you have to reconstruct completely with tendon or the internal brace, reducible and axial loading, and no degenerative changes. This is mandatory. If you have a damage, changes, and is not reducible, you cannot do that. This is bone ligament bone proposed by Queneau. We used that several times. This is another kind in the lateral side proposed by De La Rosa. It's completely arthroscopic. This is a technique proposed by our friend. Is a box technique proposed by PCO. You can perform that by open or by arthroscopic. This is an arthroscopic technique, the imaging given to me by PCO. And published a lot of years ago, more than 10 years ago. But with a specific indication. When you have a translation of the ulnar carpal bones, ulnarly, you cannot do this kind of surgery. You need to include also the reconstruction of the extrinsic ligament. And to do that, you need to use the Brunelli technique or Van Ebelel technique or Marc Garcia LT and more other techniques. This is the technique that I like for open surgery, but you can do also that by arthroscopy. This is the technique proposed by Bain, and this is the technique proposed by Henry, and this is another technique proposed by Descartes. So you can see that there are a lot of technique. This last is a technique proposed by Correa, totally arthroscopic, but was completely changed recently by him, including the double reconstruction, and this is the spiral reconstruction proposed by Garcia Elias, modified by arthroscopic by Andrea Zey, and this is valid for reconstruction of the ligament, scapholunate, and the extrinsic ligament, the condition in which you have a ulnar translation of the carpus. This is the technique, very difficult but fantastic. And this is the condition, the resection technique in which you have the static non-reducible scapholunate dissociation with chondral or osteochondral damage. Osteochondral damage in the red line, in the red in the right side, you can see the position in which you can have the osteochondritis in the position of loading, and this is the correct indication for not make a reconstruction, but make a resection and reconstruction. You can use the salvage position in this condition, like a proximal row carpectomy, scaphoid resection, and mid-carpal tenodesis proposed by Eros Palau, partial arthrodesis, 2, 3, 4 bone fusion, or arthroplastic, or completely arthroscopy. This is the proximal row carpectomy by volar dorsal approach. This is the scaphoid resection with mid-carpal tenodesis proposed by Eros Palau. This is the 4 bone fusion. I use the double column technique, and I submitted recently the paper at the Journal of Wrist, and I'm waiting for accepting the technique on more than 200 cases. And this is the algorithm of the proposition that I showed now, in which are included the reinforcement, reconstruction, and resection technique. In conclusion, the terminology is important. This terminology is strongly suggested, and I invite you to use the correct terminology to permit the understanding, the technique, and the lesion that you are treating. Thank you very much.